Welcome to the Decisive Connection, or TDC, and I'm your host, Brett Deister. And a little bit about me is that I have been podcasting for about 8 years. I'm excited to do this podcast with Coding Corporation, so thank you for that as well. But I'm going to tell you guys to always please subscribe to the podcast. That includes Apple Podcasts, Google Podcasts, or Spotify, or wherever you get your podcasts as well. But this week on the first episode, we are going to be talking about blood transfusion sets with Brian Brown, and he is a U.S. Army veteran. He's been a combat medic, so thank you for your service. He also has a BA in biology and chemistry from JSU. He also has an MS in physiology from Life University, and he is an independent medical associate and senior territory manager, product specialist as well. But welcome to the show, Brian.
Welcome. Thanks for having me.
Are you a coffee or tea drinker?
I'm absolutely a coffee drinker. My wife's a tea drinker, and I just don't understand them. So they are very, very odd people.
Is there any favorite coffees you like, or you just not like tea at all? What's that all about?
I'm a Baltimore boy, so I was born and raised in Baltimore, and I grew up on Dunkin' Donuts coffee. So I don't jump into the chapalaka frappuccino kind of world. I'm just give me a Dunkin' Donuts coffee with a little fat milk and a Splenda, and I'm good to go. So pretty easy to please. Pretty easy to please. And luckily, there's one a whopping 5 minutes from my house, so I visit them often and know them by name. So,
what is the reason I would use a transfusion set or an infusion set?
So when you look at transfusion versus infusion, you really got to. It really comes down to what you're delivering, right? So typically, when you're using an infusion set, you're doing some sort of IV solution or medication. When it comes to transfusion, it's usually from blood. You're usually transfusing blood.
If I'm transfusing blood, what does the set look like?
So a typical set, and I just happen to have one here. So I'm trying to pull this out. So a typical set, well, you usually have some spikes at the very, very top of it with some clamps. And we actually have some row clamps and pinch clamps on this one. One would usually go into the blood that you're trying to infuse, and the other would usually go into a normal saline solution. It will go down to a blood filter, right? So the AABB says that you need to use a blood filter every time that you infuse blood, or transfuse blood. And the size of the filter is kind of important, so it needs to be a range between 170 and 200 microns. That drops down to what we have as a drip chamber, so you fill the blood up to this level. And what that's basically doing is measuring your rate. And then on this particular set, we have a couple more clamps. And then here on this particular set, we have a couple injection ports where once you deliver your blood, if you wanted to give some medication afterwards, you could do that. You always have to put some normal saline through the line before you do anything else. You generally cannot give any medication with blood, so you have to flush the line out. And once you do that, you could attach a couple ports or attach a couple meds to these ports. These have stopcocks on them, so you can turn them on, turn them off. And once again, like another additional port. And that comes down to where it would connect to your IV site itself. So that's your basic set. These can be really fancy, or they can have some ports on them. It really is up to the manufacturer or the end user. One of the things that's also important is the materials that you use. Propylene is I think I said that right, because I always mess up on that word. So you don't want any type of plastics that can cause leaching, and leaching meaning some of the materials of the plastic can get into the blood. So that's another important aspect of this as well. So there's your basic set. If you compare that to like a basic IV infusion set where you have your spike, a little flow cap, your drip chamber is much smaller. There's your clamp, and you just have some basic tubing, and that in itself connects to your IV. So very, very different sets. No Y's off of this. And this you can just deliver anything, particularly just IV solution. You could have a port off of here, like a mechanical valve, if you want to give some medication. They usually call that a piggyback. There's kind of the difference between your two basic sets right there.
Does the way I deliver blood matter if I'm in an emergency situation such as an EMS or in a hospital OR?
Yeah, that's definitely the case. Usually, if you're like an emergency situation, if you have a trauma in the emergency room, you're usually giving blood very rapidly. And usually, if you've cut an artery, right, and you have a depletion of blood volume, you need to replace that blood volume as quickly as possible. So the rate in which you give that, and really the temperature in which you give that, are going to be, substantially different. Typically, you give blood over about 2 hour period of time, and you're intermittently checking IVs or doing the IVs. So you're intermittently checking the patient's vital signs about every 15 minutes to make sure everything is good to go. But in a trauma situation, I've been in quite a few of them in my life. You get the emergency room, they do what they call a cut and cross. So they go to the lab real fast, you draw some blood, they come back, they have what they call a mass transfusion protocol. They get that blood to that patient as quickly as possible because literally we're talking about blood pressure dropping, right? So you usually have IVs going wide open, and then if you're trying to replace that overall volume of fluid, just because it's emergent. You could also see that, say, in the OR if something happens, say, a surgeon nicks a vessel and they start bleeding rapidly as well. Typically, in cases like big OR cases, OR actually have blood in the OR waiting on them, usually in a cooler. So they can start doing that blood right away. But in a more ICU, med surg environment, it's a much more controlled, kind of slow paced environment when you're giving them blood.
How rapid can I give blood?
So, as I was saying earlier, usually you want to give blood over about 2 hour period of time, 2 to 4 hours. Blood, there's a certain amount of time where blood can only stay at a certain temperature, right? So when the blood comes from the blood bank, it's usually in a cooler. It's got to stay within a certain temperature range. Once you warm that blood up, you're then going to have a time window of 4 hours where you got to give that blood. If you don't give that blood over that time, then that blood is what they refer to as expired. And there's all sorts of products out there as well that may let you know if that blood's gone over that temperature range. And if that's the case, if you don't use that blood ends up getting thrown away. So usually they want to make sure give that blood within that specific time range, because of 2 to 4 hours. And then once it's past that, then it's reached its out fate, and basically the molecules in the blood, right, the cells, they start lysing and breaking down, and then that blood can actually become toxic at that point.
Does blood need to be warmed to prevent hypothermia?
If at all possible, yes. But in an emergency situation, that blood's coming usually pretty cool because it's in what they, like I said, that man's transfusion protocol. So they give that blood as rapidly as possible to do that blood volume loss. However, we'll deal with the hypothermia effects of it later on. Okay, you kind of have to do the ABCs. You can't really worry about the hypothermia initially. You just give that blood as quickly as possible to build up that total blood volume, get that blood pressure up. Once you're there, then you can deal with the temperature issues. And if you're in a controlled environment, you'll often see blood warmers used, where they'll give it nice and slow through a blood warmer to reduce the overall temperature effect on the patient.
What are some examples of the solutions that would be used in an infusion set?
So normally, when you're looking through a transfusion set, through a transfusion set, you're really looking at just blood, right? Because blood goes through a transfusion set, and you're only going to have blood, normal saline. Now, if you compare that to an infusion set, that's very, very different. So you can do all sorts of different IV solutions, normal salines, the gold standard, LR or lactated renders, or ones that have different levels of dextrose in them. Also, you can give lots of different medications, say TPN or lipids, to give your patient the nutrients that they need. And of course, obviously, drugs. So any type of blood pressure drugs, antibiotic drugs, things to lift pressure up, lift it down, or antibiotics for that. So that's why when you start looking at the difference in the transfusion sets and the infusion sets, they look different. That's because what they're infusing is very, very different.
What are other tips you can share with our audience?
Or you mean, yeah, so the infusion set. Yeah, like I said, with the infusion set, like I said, you're definitely going to be using more IV solutions, right? So lactated ringers, like a 5 dextrose or some normal saline, those are the things that are going to really determine the difference, right? Blood or transfusion set, you're transfusing blood. So the only thing that's really compatible with blood would be normal saline. Think of normal saline as the solution that's in your tears or even your spit. First, it's the solution that's in your body, so it's already compatible with blood. Infusion, different IV solutions. You're putting different nutrients into the body, antibiotics, drugs, different IV solutions, things, colloids, crystalloids, things like that. They can expand total blood volume, things like that.
Where can people find you online?
So one of the things that I spent quite a bit of time on in the infusion world is and maybe we could do another talk about this. I spent a lot of time in the neonatal world, being someone who's 1972 29 weeker. I really enjoy spending time in that space. Just I'm here because those nurses helped me out, so I enjoy spending time in that space, and I've really got to know and understand the infusion world in that neonatal market, and how things are done are just vastly different from what you can do from an adult, right? You and I, we can deliver blood if I'm getting blood, you can deliver blood to me as rapidly as possible. The only thing that really limits how quickly you can deliver blood in an adult is the size of the IV catheter that you can put in them, right? In a neonate, you're talking really, really, really small volumes, right? I mean, these guys are, it's pretty common to deliver 24 weekers these days. I mean, sometimes you hear about 22 weekers, and I think that happened in UAB in Birmingham, which is just astonishing to think that you're getting a 22 weeker. But how blood's delivered from that, from the neonatal market to an adult market, is vastly different. And you guys make a product we call neonatal syringe set, and it's basically just this has a spike with a filter on it, and it has a syringe on it. So what they end up doing is in the blood bank they have what they call a mother bag, and they're able to sterile weld this tubing into that tubing. They filter the blood. They just draw back, and the blood goes through the filter, and it comes back, and then they clamp this area off. So this end, excuse me, they clamp this off. Okay, what they call it, a heat seal. So what ends up going up to the blood bank is a already filtered syringe. And what's great about this in the neonatal world is that the label is already on the syringe. This is an important fact because when you get to the NICU, then the nurse literally just disconnects this and she plugs this into that tubing, and then you have already filtered, already labeled blood, easy for the NICU staff to use, and then they infuse this very slowly over time. And usually we're talking much smaller volumes because your kids are much, much smaller. So, I mean, if you're a low birth weight kid under 1,500 grams, if you get 20 cc's of blood, that's a pretty large amount over your total volume of blood. But some kids get much more, and sometimes they'll even give on some of the bigger kids, like in ECMO centers, they're nonstop going through these sets over and over again. But these sets are just a wonderful thing in the neonatal community, and makes the nurse's job, the blood tech's job, so much easier. If they don't do it this way, what ends up happening is the blood bank will send a pouch of blood up, and then the nurse themselves has to spike the blood, pull back, and try and filter it. There's not a lot of great filters on the market outside of these that can do that very well. Now, particularly within the AAV guidelines of 170, 200 microns. And so then they have to filter themselves. And it's just cumbersome, a way of doing it. So one of the great things about Kodan is they make everything from where the spikes go on all the way down to, like, say, this is a neonatal infusion set, like an IV set. So it doesn't matter which department they're in. They can either make a set for you, or most often, since they've been in this space so long, we have an idea of what's useful out there, whether you're in anesthesia, whether you're in a neonatal ICU, whether you're in adult ICU. They have the ability to make these sets for you. And these sets are really valuable in delivering medications and separating medications. Like this medication set, for instance, it doesn't have any mixing of the lines. That is a very useful part. One of the things, the tubing's very narrow, right? Filter sets are already added. I mean, what we're doing is we're reducing touch contamination. So every time you make a connection or disconnection in the neonatal world, that's a chance of increasing infection. Those kids already have very low immune systems. So anytime you can reduce their chance of getting infection rates, that's awesome. One of the things Codan does is they're really good about making like certain type of clamps for it. So the medication that connects to this tubing happens to be yellow, so it makes it easy for the nurse to identify the yellow medication to the yellow clamp. This is the appropriate filter to go through it. Same thing with this line. This line actually has lipids. Lipid is a white solution, so we're doing everything we can to really make the job of the clinician easier, to reduce possible failures of medication errors. So just making sets like this, they just do a fantastic job of it.
Any final thoughts for listeners?
So you can find IMA online. So obviously IMA is Independent Medical Associates. We're a specialty care distributor based out of Largo, Florida. We have our website, and that's www.i-ma.com. We're also on LinkedIn, as well as all of our sales reps. We're all on LinkedIn. And of course, CodanUSA.com. That's where Codan is at on the web. And feel free to reach out to us. We cover the spectrum of all departments within the hospital. So whether you're just doing basic IV infusion, if you're in anesthesia with more complex sets, say even cardiac cases or orthopedic cases, we're in the adult ICU, we're all over the place. Neonatal ICU, as I mentioned earlier, we can really customize and specialize whatever type of transfusion IV set to your hospital's needs. And these guys do that very well.
Any final thoughts for listeners?
No, just I think it's super important that whenever you're spending time with one of your vendors, make sure they understand the department, because each department has a little bit different niches and needs that they need. Neonatal world needs real small priming volumes. Sets that don't go together. If you're in the anesthesia department, those sets tend to be more complicated with manifolds. So make sure when you're spending time with your manufacturers that you understand the clinical reasons for your sets, because that can better help you get the clinical outcomes that you're really looking for.
All right. Thank you, Brian, for joining TDC and sharing your thoughts on the blood transfusion and infusion sets.
Hey, thank you very guys so much for having me. And by all means, if there's anything else I can do for anyone out there, my name's Brian Brown. I'm based out of Atlanta, Georgia. Feel free to hit us up anytime.
And thank you for listening to TDC. As always, please subscribe to TDC from all your favorite podcasting apps, including Apple Podcasts, Google Podcasts, and Spotify. Leave a 5-star review. It will really just help with the rankings. And guys, have a great week and see you next week. Later.